group. And at various points in your life, personally and professionally, you have relationships with people that really stay with you. So when I worked with these civil rights workers, one of them was John Lewis, who many of you who saw the inauguration saw John as one of the key figures in the civil rights movement, and to this day, the congressman from the district in Atlanta. I had a similar experience with a family that in the book I called Mary and Kate, a mother who struggled with very difficult mental illness, but also was profoundly committed to taking care of her children and to making sure that they did it all right. And it convinced me that people have this capacity despite her. And then her daughter, who had at times a troubled relationship with her, but on the other hand came out on the other side. And this woman had 3 kids. Kate had a sister and a brother, and they were, in their adulthood, very good friends. So we asked, and when we did this work, we also asked people, well, what would help if we were dividing the program? What would help people in this situation? This is what Kate said. First, somebody should explain why people get depressed. You really don't know what it is and if it can happen to you. You don't know why your parent feels that way. You don't know if you're going to feel that way yourself or how to manage it if you do feel stressed. If someone has a disease, you want to know how he or she got it and how you can prevent it from ever happening to you. Otherwise, you have fear. You can't trust something that doesn't have an explanation. And then this is what her mother, Mary, said after a long struggle with illness coming out on the other side. It's important for kids to be brought up in a house where they can express themselves. In my childhood, we never had that. It was difficult when I grew up. Bad feelings were something I feared, something I suppressed. My kids can be able to, if there's a problem, we talk about it, try to figure out what's going on and how to fix it. And I think that emphasis on conversation, again, was one of the crucial ingredients in our intervention, as was trying to answer children's questions. And just to provide a little context, I started out in 1979, did an early study of children and parents with mood disorders that became an IMH-funded study. We looked at risk, we then went back and looked at resilience. Starting in the late 80s, I began to pilot interventions for families with depression, and then received 2 NIMH grants in sequence to follow 100 families with 2 forms of preventive interventions over a number of years. All the families were followed for 4.5 years. Many of them followed for as long as 10 years. We found good results. I'll say a little bit about that. And then we began to replicate and explore these interventions in other ways. Family 4 in Dorchester was replicating it with a single parent African-American set of families. The narrative reconstruction was having one person read over everything the family had said to us, try to write a narrative of it, and then often go back to the family and said, did this happen? And that's how we built the stories in the book. And then since 2000, we've been involved in various kinds of endeavors, trying to help different groups figure out how to develop effective programs to strengthen families. I mentioned the work in Dorchester. We've done a similar kind of work. The Dorchester work is a randomized trial that Latino families work. And I think I included the reference there. Was an open trial, 9 cases with good outcomes. I'll say a little bit about Finland. Finland is the leader in doing a large-scale countrywide implementation of a program for children mentally ill. I feel a great commitment to Head Start. Julie Richmond was the first director of Head Start. In 2004, Head Start came to me and said, would you help us develop a program about parental depression, because the rates of depression in Head Start are as high as 50%. Head Start and early Head Start is 0 to 3, Head Start is 3 to 5. These are center-based programs that combine education, health, social emotional development, and parent involvement. And they're means tested, meaning they're primarily for poor families. And so I'll tell you a little bit about that work. I mentioned the work of the Blackfeet. We're doing a nationwide program in Costa Rica that is well on its way. And we've used these ideas in other investigations. I'm actually working with a group from UCLA on Project Focus, which is combining our intervention with a family-based intervention for AIDS and a family-based intervention for trauma, and actually using it with service personnel who've got multiple deployments overseas and helping families deal with them. Think about what does a child go through if a soldier parent is gone for 3 of the first 6 years of a child's life. So that's a group at very high risk of contact, but I think equally important. And all the work we've done is in the public domain. I'll send the manuals that we have to anyone, the training tapes. I'm delighted to offer training and consultation, and the Head Start work is on the web, and I gave you that link to that to be downloaded as well. Now, think back to, imagine yourself as Bill Beardsley in 1985, okay, having just received the Faculty Scholar Award from the Grant Foundation, which was a wonderful award that Bonnie and Ron also got those awards, and that formed the family community, to try to develop preventative interventions at a time when there was really no manual-based preventive work for families. And certainly not around depression. At least in the States, much of the work on depression is centered on individuals. People get so fascinated with neurotransmitters, with fMRI, and with various things like that. And I had also trained in a whole bunch of elite, I was a psychoanalyst, I trained in Milan systemic family therapy, all these things. And none of them were very relevant to public health prevention. So if you think about what the task is, it's to be compatible with a range of theoretical orientations and to be used by a wide range of health practitioners. That's the only way preventive interventions will be taken to large scale. Strong cognitive orientation, because depression distorts cognition in many, many different ways. And there's lots of evidence about the efficacy of cognitive, behavioral, and interpersonal treatment. Inclusion of the family as a whole is something I believe in very strongly. You know, that's what families are. But our health care system splits them up into the child, or the child with this illness, or the parent with this illness, or not even the parent, the person with this illness who's an adult. So you need to think about how to center that differently. And I think families have different experiences in general, but they particularly have them around things like depression, which can't be discussed. So bringing the family together. And then a developmental perspective, we started this work working with kids, with families who had at least one kid age 14, because the risks for depression go up dramatically after puberty, and we wanted to get to them before that. And what we came to as the core elements of the intervention were assessing everyone, presentation of psychoeducational teaching material, depression is a biological illness, it's known as these are some of the characteristics of resilience and how they can be built, and then linking that material to the family's life experience. Decreasing guilt and shame by directly and explicitly saying this is not an illness that's anyone's fault or blame, and then helping figure out the way that what had been disrupted through depression could be put back together, particularly for the child's relationships and the child's independent development. And then